you, Dr. Thank you, Dr. Goenka, for kind introduction. And also thank you, Dr. Sibal and Dr. Jain for joining hand with Indian Society of Gastroenterology. Our greetings from member of ISG and also the Governing Council of ISG. We welcome all of you. As Dr. Goenka said, that Indian Society of Gastroenterology, the parent organization of all gastroenterologists practice in our country, and society is very active in doing many educational activities. And we focus more on training activities, and a lot of activities go on every year. We also invite you to join our Congress, our annual Congress, which is going to be held in Jaipur on January 5 to 8 in 2023. With this, I hand over and welcome all of you again, and thank you for inviting us to join for this program, which is a very, very important topic. There's a fatty liver disease. With that, I hand over to Dr. Goenka to take the proceeding forward.
I'm still waiting for Dr. Shankur Rao to join, but we will proceed with our program. And our first speaker today is Dr. Kaushal Madan. Dr. Kaushal Madan is the director and head of clinical hepatology, gastroenterology, endoscopy, and liver transplant and biliary sciences at Max Hospital, Delhi. He has more than 28 years of experience in all the GI diseases, including liver diseases. He has his expertise in cirrhosis, fatty liver disease, hepatitis B, hepatitis C. He has a fellowship of Japanese Society of Gastroenterology, research fellowship at Kinki University School of Medicine, and has published more than 50 research papers in peer-reviewed journals. Excellent speaker, as you will see. So Kaushal, it's you now.
Thank you so much, sir, for the kind introduction and the invitation. And I must thank ISG and GAPIO for joining hands. And I can see the strength. I think within last 5 minutes, we suddenly have had a spurt of participants joining this meeting. I think just 5 minutes back, there were 40, and now they are more than almost touching 90. So thanks for inviting me for this particular session, Dr. Anupam Sibal, Dr. Jain, Dr. Govind. Just give me a second so that I can share my slides. Yeah, are my slides visible?
Yes.
Yeah, so I've been asked to speak on etiopathogenesis and burden of non-alcoholic fatty liver disease and the risk factors associated with it. So let me start by talking for a few minutes on etiopathogenesis. We all know that we've been hearing about the first hits and second hits in non-alcoholic fatty liver disease pathogenesis. The first hit is the liver fat per se. And some people say that insulin resistance is the first hit, which leads to liver fat. So whether insulin resistance comes first or liver fat comes first is not very clear with the studies which have already happened. But we know that in a genetically predisposed individuals, the one who has environmental risk factors also, specifically high fat and high carb diet, there leads to alteration in the microbiota or dysbiosis or a predominance of pathogenic microbiota, which leads to the lipopolysaccharides going through the portal vein into the liver and other bacterial products which are called pathogen-associated molecular patterns, which reach the liver through the portal vein, and then they occupy the receptors on the Kupffer cells which are present in the liver. Kupffer cells get activated and produce excess TNF-alpha and IL-6, which are responsible for producing intrahepatic insulin resistance and steatosis. This is how the first hit happens. Thereafter, this progresses through stages of necroinflammation and then to liver fibrosis. We all know, and we've learned over the last 1 or 2 decades, that it is the liver fibrosis which is the major driver of adverse outcomes in patients who have non-alcoholic fatty liver disease. Sometimes liver fat directly progresses to liver fibrosis without the intermediate stage of liver necroinflammation, and this specifically happens in people who have diabetes or metabolic syndrome. And there are many drivers in between. These are called, you may want to call them second hits or multiple hits. You must have heard about the multiple hit hypothesis of etiopathogenesis of NASH. So these are those multiple hits: the oxidative stress, inflammatory mediators, cytokines, and apoptosis producing enzymes or chemicals which lead to progression of liver fat to necroinflammation and liver fibrosis. So just to give you an example, this was a study which we had done at AIIMS long time back, in which we compared a group of patients who had NAFLD, chronic viral hepatitis controls and healthy controls. And we found that the oxidative stress was significantly higher in patients with NAFLD and not chronic viral hepatitis, suggesting that oxidative stress is one of the important drivers. And lo and behold, the most common drug which is used in non-alcoholic fatty liver disease, that is vitamin E, acts on this particular target. And then there are modifiers of the insulin resistance, the inflammatory cascade, and the fibrotic pathways. These are the nuclear receptors called PPARs, or peroxisome proliferator activated receptors, or the farnesoid X receptors. And now we have drugs which are targeting these particular molecules, which modify the course of the disease in patients with non-alcoholic fatty liver disease. So this was, in short, the etiopathogenesis of non-alcoholic fatty liver disease. Let me now go over to the burden or the epidemiology of NAFLD. Let's look at global burden. You just heard Dr. Anupam Sibbal talk to you about the global burden, and that's what I'm going to talk about. In fact, what he has covered in short, I'll just elaborate that. So this was the study of, it was a meta-analysis of 86 studies from across 22 countries, more than 8.5 million subjects. And this was the global prevalence they found. It was 25.2%. If you look at the prevalence in various regions of the world, you can see that it was highest in Middle East and South America, but the number of studies there were very small. About 27% in Asia, 23% in Europe, and 24% in North America. So again, giving an average of about 25% of the world population suffering from non-alcoholic fatty liver disease. Looking at age-specific prevalence, it starts to rise around the 4th decade and continues to rise till about the 7th decade, where it is almost 33% in this particular study. This was that global study. Looking at the sex-specific prevalence in males, you can see that around the 3rd or 4th decade, it starts to rise and then plateaus around the 6th or 7th decade. Similar pattern is observed among females, although the overall prevalence might be slightly lower. But if you remember the original description of non-alcoholic fatty liver disease, we used to be taught that it is a disease of middle-aged, obese or overweight females. But I think over last couple of decades, we've learned that it's probably more common in males. Looking at the metabolic risk factors or the drivers of the disease, we see that obesity is one of the most common comorbidities or metabolic risk factors, others being diabetes, dyslipidemia, hypertension, and metabolic syndrome per se. And when we look at NASH, NASH is the more severe form of non-alcoholic fatty liver disease, or the disease which actually progresses to advanced liver-related outcomes. And as you can see, as compared to NAFLD, in NASH, the prevalence of these risk factors is even higher, suggesting a dose-response relationship. And remember, dose-response relationship implies causality. So these are possibly the risk factors which drives this particular disease. What about epidemiology in India? So there are several studies which have been done. So some are hospital-based, some are population-based. So let's start with the hospital-based study. This was the study from PGI Chandigarh among 986 male blood donors who presented to PGI Chandigarh. And 53% of these patients on ultrasound had fatty liver. This was done by Dr. Duseja, and you will hear him in the third talk. But obviously, there is a problem here that this may be overestimating the prevalence of non-alcoholic fatty liver disease. Possibly the urban population who comes for blood donation possibly is represented by these patients. What about autopsy studies? This appears to be the more representative of the kind of prevalence which may be there in the society per se. So these were 103 consecutive victims of fatal road traffic accidents and fatty liver disease on Autopsy was diagnosed in 14.6%. Remember, this is as far back as 2004, still in the abstract form, but obviously this does not exclude the presence of alcohol intake. So with that has to be excluded when we are defining patients who have non-alcoholic fatty liver disease. Coming to population-based studies, I think this is the most oft-quoted study of prevalence of NAFLD in India. This was a very well-conducted study by Dr. Abhijit Chaudhary's group. Rural West Bengal, 7,000 subjects, of which 1,900 were selected. Ultrasound revealed 8.7% had fatty liver. So in rural area, in rural West Bengal, 8% patient had fatty liver, of which 2.3% had inflammation in the form of raised ALT. And this is very significant. 0.2% had undiagnosed cirrhosis. 36 of these underwent liver biopsy. 0.2% of a rural population in India had cirrhosis. Now extrapolate that into the entire population of our country. That's a huge burden of cirrhosis, which we are supposed to manage in future. And looking at the risk factors in this particular study, obviously we all know that abdominal obesity and dysglycemia are risk factors, but significantly, even fasting blood sugar, which was more than 100, was associated with a higher risk. And look at this, even a family income, which was $1 to $2 per day, had a higher risk. More than $2 per day had an even higher risk. Similarly, a BMI, which was less than 24, 18 to 24, was associated with higher risk of non-alcoholic fatty liver disease in this population. What about urban population? This was a study done in Chennai among 541 participants. 32% patient had NAFLD. So 8% in rural, 32% in urban, mean age of about 46 years. This was a study done by late Dr. Amrapurkar, 2 railway colony residents who were screened in Mumbai, and about 16 to 17% patients had NAFLD. So again, urban population, 17 to 18%. These were the risk factors. So coming to a recent study, these were all studies done almost a decade back. So this was a study which compared urban and rural population from a place which is close to Delhi, where in Ballabgarh. So urban population were patients or people coming to AIIMS per se, New Delhi, and rural population was the PHC, which is handled by AIIMS, which is at Ballabgarh. But look at this, if you compare the population, their BMI, look at the BMI, not much different. Even the rural population had a high BMI. If you look at the definition of obesity in Asian Indians, it is more than 25, unlike Western. So 49% were obese, 19% were overweight, 14% had diabetes. This is in the rural area. And look at the prevalence. Urban area, 65%. Rural area, 61%. NAFLD with high ALT, 23%, 22%, almost similar. And this is the most important figure I've always been highlighting. I highlighted this in the previous study in rural population. 0.2% had cirrhosis. Here in urban population, F4 fibrosis, 2.8%. Rural population, 0.6%. So even if we take an average, so 1% of the country's population possibly is having undiagnosed NASH-related cirrhosis. Coming to prevalence in high-risk groups. So this was a study which we did in AIIMS long time back. Patients who come with asymptomatic transaminitis, patients who go get an executive health checkup done, they are found to have raised AST, ALT, and then they come to you. 36% in them, this is the most common cause in them, that is non-alcoholic fatty liver disease. Similar result from Dr. Sareen's group. Among diabetics, this is a very important issue I am coming to. These were the previous studies, and look at this. Patients who have diabetes, unselected patients, almost half to 2/3 of these patients will have non-alcoholic fatty liver disease. And the interesting part starts here. When you further dissect what happens to these patients, the diabetics who have non-alcoholic fatty liver disease, 1/5 of these patients have advanced fibrosis if you do a liver biopsy. Another study, 37% patient had fibrosis on biopsy. the unselected diabetics. Now, again, I'm taking you, those were old studies. I'm taking you to a recent study which was done in a corporate hospital close to New Delhi. 531 consecutive patients of diabetes unselected underwent a fibroscan. 84% had fatty liver. And look at this. Almost 30% patient had more than F2 fibrosis and 7.2% had more than F4 fibrosis or cirrhosis. So diabetics is a group which is a very high risk group for harboring advanced fibrosis or undiagnosed cirrhosis. Now, patients are undergoing transplant. How many of them turn out to be NASH-related cirrhosis underlying? So this was a study from Gangaram Hospital, 103 explanted livers. 30% in the pre-transplant period had a diagnosis of cryptogenic cirrhosis. 63% were turned out to be NAFLD-related cirrhosis. And again, a recent meta-analysis done by Dr. Shalimar from AIIMS, 38% of all studies on an average have shown that 38% Indian population may be harboring non-alcoholic fatty liver disease. And the most interesting part, here it comes, 35% of children, Dr. Anupam Sibal talked about this, 35% of children in India may be having non-alcoholic fatty liver disease. And these are the feeders for future development of NAFLD in adults. And these are the patients who have been having fatty livers for decades and therefore are more likely to have fibrosis and cirrhosis when they reach adulthood. So let's look at the time trends. So these are three large NANE survey. These are done in US National Health and Nutrition Evaluation Surveys. The first 98 to 94, 99 to 2004, and 2005 to 2008. Look at this. NAFLD prevalence 5.5, 9.8, 11%. Progressively rising, and this was as of 2008. Now we are standing in 2022. And this paralleled the rise in the risk factor, that is type 2 diabetes, as well as obesity during these time periods. And there were similar trends for hypertension and insulin resistance. So this was the prevalence of time trends of prevalence of newly diagnosed cirrhosis. And if you look at the etiologies, so these are the etiologies for chronic hepatitis C and ALD coming down, NAFLD progressively rising. Etiologies of underlying chronic liver disease in patients who are on liver transplant wait list. Chronic hepatitis C coming down, non-alcoholic fatty liver disease progressively rising. Now this is liver cancer, patients who are liver transplant candidates and also having liver cancer, more than 1.5 lakh transplant candidates. In 2001, proportion of NAFLD related HCC were only in 2002 was 2.1%. 2016, it has risen to 16.2%. And during the same time, it decreased for chronic hepatitis B, remained the same for chronic hepatitis C and ALD. What about the burden in years to come? Again, I think Dr. Anupam Sibal talked about this. This is a very important issue. More than 2.4 lakh boys and girls between 7 and 13 years of age, followed up for 39 years. The risk of NAFLD in adults for per unit increase in BMI in these boys and girls, if they had a BMI which was, say, 24, if we talk about a BMI of 25, it was associated with this kind of hazard ratio. So higher the BMI during their childhood led to future development of non-alcoholic fatty liver disease when they became adults. Another study in adolescents, 1.2 million men, 34,000 person years of follow-up, more than 5,000 developed severe liver disease. And the risk of developing severe liver disease in adulthood was directly proportional to being overweight or obese during adolescence. Again, children between 7 to 13 years of age, they were followed up, 438 developed liver cancer. And what the development of liver cancer was associated was with the BMI Z score. Higher the BMI between 7 to 13 years of age, higher the risk of development of liver cancer later, independent of alcohol exposure, viral hepatitis, or biliary cirrhosis. Those were studies from the West or US. What about Indian patients, Indian children? This is the prevalence data from 52 studies from 16 Indian states. And as you can see, from 2001 to 2010, there was a progressive rise in the prevalence of overweight and obesity. Now, again, we are standing at 2022. I'm sure this has risen further. And finally, this is a very interesting study which used prevalence data of obesity and type 2 diabetes in population-based studies to find out the estimates of NAFLD and expected prevalence in general population. Use those estimates in a Markov model to predict outcomes in 2030. This is very interesting. So this is a US data. From 2015 to 2030, 21% rise in prevalence of NAFLD, 63% rise in prevalence of NASH, 168% rise in incident decompensated cirrhosis, 137% rise in HCC, and 178% rise in incident liver-related deaths. So I'll finish here and I'll just summarize. The global prevalence of NAFLD is about 25%, that is 1/4 of the world population. In India, it is about 8% in the rural population and about 18 to 65% in the urban population. In special population, is especially high in transaminosemia patients, almost 40%. Patients who are diabetic, almost 2/3 to 3/4 of them are having non-alcoholic fatty liver disease. And they are more likely to have advanced form of NAFLD, that is NASH, or having advanced fibrosis. The risk factors we've already talked about are obesity, diabetes, dyslipidemia, advanced age. So there is a predisposition, there is insulin resistance, liver fat, necroinflammation, and fibrosis. The trends show a rising prevalence of NAFLD and its complication. Over the next 10 years, there will be a rise in prevalence of NAFLD, NASH, cirrhosis, liver cancer, and liver-related deaths, and a steeper rise in complication than the basic disease per se. And please remember, the major feeder of future NAFLD is pediatric obesity, pediatric overweight, pediatric NAFLD, which may be driving this disease. So I thank you in the end for a patient hearing, and please say no to childhood obesity. Thank you so much.
Thank you, Dr. Kaushal Madan, for telling us about the epidemiology as well as the tumor burden and exposing us to dreadful future, which it seems to be with the NAFLD being so common in the childhood, particularly the obese children. I think we'll have some question answers after the other two talks. I would now invite Dr. Akash Roy, who is my colleague at Apollo Calcutta. He has done his DM in hepatology from PGI Chandigarh and then worked as a consultant in prestigious SGPGI Lucknow. He has received a number of awards, including the Best Oral Presentation in Singapore Hepatology Conference in last year in 2021 and Best Oral Platform Presentation at the Annual Conference of API in Hyderabad. Dr. Akash, you have about 15 minutes. We'll have to finish in 15 minutes,
Akash. Thank you, sir. Firstly, I would like to thank Professor Goenka, Professor Makharia, and Dr. Sibal for this opportunity and the entire associations of GAPIO and ISG for letting me a part of this and allowing me to walk you through towards the diagnosis, including the non-invasive tests of NAFLD. We have a crowd which is mixed, so we'll try to make it simple for an understanding of a disease which is global and has got global implications. So coming to the diagnosis of NAFLD, the very diagnosis of NAFLD starts with the definition of NAFLD. Non-alcoholic fatty liver disease refers to an evidence of hepatic steatosis, which can be by imaging or by histology, when you have excluded secondary causes of fat accumulation, of which the most important is significant alcohol consumption, which has got its own limits of definition, of use of other medications, and again, hereditary disorders. As already pointed out by Dr. Kaushal Madan, that it has got three cardinal associations of obesity, diabetes, and dyslipidemia, and metabolic syndrome as a whole, and it has got subtypes. Somebody can be obese in NAFLD, somebody can be overweight in NAFLD, and there is a subgroup who can be lean but have those metabolic components and have NAFLD. Plus, at this onset, there was a growing understanding that because of the prevalence of a disease, which is going up to the tune of 25 to 30% and more, there is a possibility that this disease can coexist with some other diseases. If somebody has hepatitis B, that doesn't preclude you from also having NAFLD. If somebody has autoimmune hepatitis, that doesn't preclude you from having NAFLD. So this is a growing understanding that has come about over the past years. So NAFLD is a disease which is in continuum. It raises from isolated steatosis, that's fat in the liver, to something which makes that fat behave in a Ori manner and causes steatohepatitis, which simply means inflammation. And then it leads to fibrosis, cirrhosis, and ultimately liver cancer. So if you understand this entire spectrum, there would be a wide variety of presentations that would be having. And the diagnosis of NAFLD starts from those presentations. So the Achilles heel of NAFLD till today remains that it's an asymptomatic disease. The common presentations that we would be getting as a physician, as a gastroenterologist, as a hepatologist would be somebody did an ultrasound and was told to have fatty liver. Somebody did an LFT, got an increased ALT and AST and was referred to. Somebody had diabetes or features of metabolic syndrome, somebody with an endocrinologist who purposely screened him and got features of fatty liver. Somebody just had an ultrasound and the radiologist told you that there is something which is suspicious and you should go up and follow it further. Or with the increasing use of techniques like elastography, you can go in and walk in and have an elastography and find a high value and again bring you to this. So this is the spectrum of the common presentations of NAFLD. And the problem with this is it is mostly asymptomatic. The other end of the disease encompasses patients who have advanced cirrhosis of decompensation and something which we would very commonly label as cryptogenic cirrhosis, a fraction of which or majority of which perhaps was all non-alcoholic fatty liver disease 10 to 20 years ago, where the fat is now gone, those features of metabolic syndrome has gone, and what remains is advanced cirrhosis. And with the burden of NAFLD increasing, it has got a direct correlation with HCC, which can be with cirrhosis, which can be without cirrhosis, and those would constitute with your symptomatic presentations. So whenever we are faced with NAFLD, make a diagnosis, what we have to assess is that how severe is it? Should I treat it or should I not treat it? And how do I monitor once I have diagnosed the disease? I'll be focusing on that part of how severe is the disease of non-invasive assessment overall. But prior to going into non-invasive assessment, NAFLD, which is non-alcoholic fatty liver only, can be anybody who has got steatosis. That can be an ultrasound, that can be on biopsy. So steatosis qualifies you to only have non-alcoholic fatty liver. But the diagnosis of NASH, which stands for inflammation, still holds down to have something on the biopsy. The cardinal feature is something which is called hepatocyte ballooning, which you can see in this image out here. And that can be accompanied with something called lobular inflammation, which can be demonstrated out here. So that makes you have NASH. But then there are two other things that decides how your disease is going to progress. How active the disease is, which is given like scores of CRN NAS scores on biopsy. And what is your stage of fibrosis, which is given by CRN again, fibrosis score. I want everybody to remember this because this is what the biopsy is going to tell you. And what we try by the non-invasive methods of assessment is to replicate these same things by methods by which we can understand the steatosis, we can understand the activity, and we can understand the fibrosis. So liver biopsy, still the gold standard, but I would rather say it's the imperfect gold standard because it comes with its own problems of safety. There's a bleeding rate which can range up to minor bleeding of 10%, major bleeding of around 1 to 4%. Sampling inadequacy because of types of lobe and which can range up to 20%. There can be sampling variation depending upon which lobe you're taking from and the variety of inflammation that can be there. And most importantly, we have a dearth of qualified pathologists who are trained to report these cases of with individual things that are reported in NAFLD. So, and with that, you add on to the fact that a walking, talking patient comes into your OPD and you ask him for a biopsy to diagnose NAFLD NASH, most of the time, the answer is a no. So what you need for that is alternative non-invasive tests. So those non-invasive tests have tried to divide. As I said in the biopsy, you look for three things. You look for fat, and that fat assessment can be done by ultrasound. There are some scores, and there are two other methods that I'll be coming to. The fibrosis assessment is again can be done by blood-based tests like APRI, FIB4, which are simple calculator-based tests, and elastographic techniques. What I've pointed out here is in gray is that part of hepatic inflammation that we had talked about when we were addressing the NAS score. That part is perhaps still the gray zone, though we have data now coming out with tests like FibroScan plus AST, which are indicative to that area of activity with or without fibrosis. An important thing to remember, many people think that ALT and AST and elevated ALT is concurrent with hepatic inflammation. That's not true. The correlation is very poor for that aspect. So somebody may have raised ALT, but the degree of activity of the disease might be very insignificant. So these are the conventional methods. This is the commonest method in ultrasound that you do to assess for hepatic steatosis. The problem with an ultrasound is difficulties in obesity. Unless the fat is less than 30%, its accuracy is limited. You can also use a CT, which can use in transplant settings, but that again has its limited accuracy in mild steatosis and radiation. And there have been steatosis indices like fatty liver index and hepatic steatosis index, which have been used, which basically take into components of metabolic syndrome and associated things. But these have not been well validated to assess hepatic fat per se. The two best modalities that we have got is controlled attenuation parameter, which is there available in a FibroScan machine, which comes from the EcoSense company and comes embedded with it, where you'll get a report like this, where they give you a CAP value, which stands for controlled attenuation parameter. These have various divisions according to which you can grade the amount of fat that is there in the liver. This test is excellent for detection of steatosis even at low levels. The only issue with a FibroScan mediated CAP is that when you try to grade this, as you can see the grades, these grades have a long variation and the validation is not yet adequate. The best method that we have till now of assessing liver fat is MR-based techniques, which starts from MR spectroscopy, which is difficult in usual scenarios, needs specific softwares and training programs. But the one which is becoming more and more available is something called an MR-PDFF, which works on the simple principle as to what is the amount of triglycerides in that tissue, which would be sending a proton signal, which is said as a chemical shift, and you can assess how much of the amount that is there. So is MRI-PDFF better than CAP? When we talked about CAP, we assessed that it is inferior when you go up to those grading of moderate to severe steatosis. Yes, in that aspect, MR-PDFF is perhaps better, but it's limited by cost and availability. And the important aspect of this, that it is gradually becoming an endpoint in clinical trials. So it has not been proposed yet. There are suggestions that in future trials, you may be taking MR-PDFF reductions of 29% as a surrogate marker of biopsy endpoints. So what about the moving from the fat assessment to the fibrosis assessment? Then again, you've got blood-based test and elastography. From blood-based tests, you have got direct tests, indirect tests, and combination tests. Out of which, what's important, what's easily available, ready with us in calculators are these simple tests of APRI, FIB4, and NAFLD fibrosis score. So these are the three which are more commonly used and uses readily available parameters that we can use daily. What's important to point out here, these tests usually come with two cutoffs. One's a rule out cutoff and a rule in cutoff, but you can exclude advanced fibrosis and you can include cirrhosis. And there remains a gray zone out there. And it's important, and we'll come to this when we go ahead as to what's the importance of these gray zones are. These are the cutoffs that has been accepted globally now and have gradually been finding their ways in guidelines that have been set up. The elastographic techniques that are there, they're basically based upon the concept that if a liver tissue is stiff, the velocity would be higher and you'll have a higher velocity. There are many modalities, again, something which can be done by an ultrasound, which is called US-based elastography, 2D shear wave elastography, variants of which are RFE, Then the FibroScan that we talked about, we got the cap values here. This is what the stiffness values that come out of the FibroScan. And then we have the MR counterpart of it, which is called as MR elastography. But as we have a global audience, what's important here to realize that there are some caveats of not doing these elastography. We don't do these elastography in somebody who's got acute hepatitis, with acute liver injury, somebody with got cholestasis, congestion, heart failure, ascites, specifically when you're using FibroScan, which is the most common modality, or somebody is actively consuming alcohol. So it's great. It's a great way to classify for fibrosis. But before that, we should be understanding where not to do it. So these are the cutoff values that has been described for these elastographic techniques. I've taken up the 3 common ones which are available. You would see that this rules out any significant fibrosis, and gradually as you go up to the diagnosis of cirrhosis. And these have got variable values for RFE and MRE. An important point out here is that FibroScan values of liver stiffness have been more globally validated, and they have got more sequential abilities to risk stratify the severity of disease. So should I choose one over the other? We have got many modalities: transient elastography, MR elastography, RFE. If you see the comparison from a recent paper, these tests mostly perform similar, except when you go into higher grades of fibrosis assessments of stage 3 and stage 4, where MRE possibly performs a little better than the other modalities. But there are some specific states where you might prefer one over the other. That means if somebody is very obese, if you want that accuracy to go high, especially in stage 3 or stage 4, MRE is possibly better. If you've got narrow subscostal space, especially in females, MRE or ultrasound-based techniques may be better. But if you see the availability, cost benefits, and accessibility, transient elastography is perhaps it's widely available, and the data with it is also most valid. So this is how we would summarize the 2 types of non-invasive testing for fibrosis: the blood-based test and the elastographic test. As you can see, the FIB-4 performs excellent. That's why it finds its way to most of the staging algorithms. And all the transient elastographies, shear wave and MRE, also have got excellent cutoff levels and AUCs for significant fibrosis, advanced fibrosis, or cirrhosis. So what this basically summarizes is that when you use blood-based NITs, they are individually, or elastography individually, they are excellent to rule out advanced fibrosis. But if you use both of them together, they are great at both ruling in as well as ruling out advanced fibrosis. And only in cases where you have discordance, you'll go for a biopsy. So taking this knowledge, we go ahead to what would be the diagnostic algorithm for patients with NAFLD. So we have anybody with NAFLD, we look and treat for metabolic dysfunction. NAFLD is a reflector of metabolic syndrome, and those metabolic problems need to be taken care of. Use a NIT, which can be FIB-4, which can be APRI, which can be in combination. If these scores are below that lower cutoff that we were talking about, this patient has got low risk. Check and look out for the metabolic factors and follow them up. If they have an intermediate or high score, go ahead with the elastography, because remember we talked about those gray zone areas where they may be misclassified. And then if it is high, there's the role of gastroenterologists and hepatologists. Otherwise, this disease is so common, it cannot be managed by gastroenterologists and hepatologists. It's the physicians, it's the primary care level who have to be involved in risk stratification of this disease. So this is perhaps what we are heading into. This is I've taken with permission from Ajay Duseja sir and Dr. Arka from PGI Chandigarh. This is the guidelines possibly we are heading to from the International Society of Liver, that you have got somebody with incidental abnormal liver enzymes or somebody with features of risk factors, diabetes, obesity, metabolic syndrome. Ultrasound is the first test. Assess non-invasive blood tests like FIB-4 and APRI. If these are below that low cutoff, follow them up, treat their metabolic dysfunctions, and suggest them lifestyle modification, because the fat is still there. If these are intermediate, high scores, or there are discordance between these 2 scores, like the FIB-4 is high, APRI is low, go ahead with an elastography. The elastography can be site-specific, but since we have the greatest data with transient elastography, you can use these cutoffs and stratify again. Again, if there is below that cutoff level for F2 F1 fibrosis in transient elastography, you can follow these people up, but keep on minding that they have to be still treated for their metabolic dysfunction. If they are intermediate, not amounting to cirrhosis, then they mandate NASH pharmacotherapy, I think, which Ajay sir would be talking about in the next talk. And if they have gone up to cirrhosis, then manage them as cirrhosis, because as of today, we do not have that much data with any drugs in patients with NASH cirrhosis. So the messages to take home is that NAFL is a global threat with alarming implications. However, the disease is composite and complex, and it has to be managed in various aspects of the society. Therefore, it's important to identify and risk stratify, because if a 25 to 30% of the global population cannot be subjected to specialist care, non-invasive methods are the way forward, because biopsy is not possible in majority of the cases. And as things are possibly with diabetes, as with the therapies for NAFL evolve, the identifying these individual stages of steatosis, of activity, disease activity, of fibrosis would become important, because we may be going into an era of individualized therapy for individual stages of NAFL. Thank you, everybody.
Thank you, Akash, for covering a very important area in NAFLD. And I'm sure there are lots of questions which will come up if we have time. We have been doing at Apollo Calcutta both MRI PDF and MRE, and we have now a huge experience of that. And I think it's going to be changing our algorithm of approach to NAFLD or MALD, as you call it. Now, let me have the pleasure of inviting Ajay Dussaisy, a dear friend from my alma mater, PGI Chandigarh. Now, Ajay is presently the professor of hepatology at PGI Chandigarh and experience of more than 25 years in the field of hepatology. He has done his DM from PGI Chandigarh and is now a fellow of National Academy of Medical Sciences, as well as a fellow of AASLD, as also the fellow of American College of Gastroenterology. More important than that, he is presently the secretary of INASL, our parent body for study of liver diseases. He is the national convener of Indian National Association of Study for Liver, task force for NAFLD, and is also the principal investigator for the Indian Consortium on NAFLD, the ongoing real-life study of NAFLD. I think he has a huge publication expertise. I would not go into details of his resume, but would invite him to give an overview of the present management of NAFLD or MALD, as he might like to call it. Ajay.
Thank you very much, sir. And at the outset, my sincere thanks to ISG and GAPIO for giving me this opportunity, especially Professor Goenka, Professor Makharia, Professor Sibal, Professor Jain. So I bring greetings to all of you from PGI Chandigarh, and let me share my screen. Is it clear?
Yes.
And,
yes.
Yeah, thank you. So as I said, I've been asked to cover, the treatment part of fatty liver disease, and I'll just be giving an overview about this. Let me first, kind of give you some Indian perspective on both the speakers before me, Kaushal and Akash. The figure of 53%, which was, shown by us in Chandigarh, we were also surprised with such a high prevalence of fatty liver disease initially. But this is the, India map study, which we did, last year and published. And to our surprise, we had other centers also, which had shown a prevalence of around 50%. And then came, this meta-analysis, which was quoted by Kaushal again, 50 studies. So the Indian prevalence of fatty liver disease is not 25%. It's close to 40%. And this has been shown now in more than 25,000 adults with 50 studies. So we are far ahead of the global prevalence. That is the first thing. And the problem is not only in adults, but also in children, which has been highlighted. The second message I would like to again say, Akash just spoke about, the non-invasive assessment, and Dr. Goenka told you about our Indian consortium on NAFLD, what we call ICON-D. So this is the snapshot. I think we just did the interim analysis and published this year a data of close to 4,000 patients. And if you look at the non-invasive assessment based on, FIB-4, APRI or NFS, close to 30% of our patients actually have what we call advanced fibrosis. And if you look at the significant fibrosis cutoff, again, based on the transient elastography, more than 8 kilopascals, again in 20%. And to our surprise, more than 13 kilopascals, which actually means cirrhosis, was seen in 10%. So mind it, these are the patients in 42 centers of our country who are presenting to the hepatologist only with incidental detection of fatty liver or incidental detection of, raised transaminases, and then 10% turning out to be cirrhotics, 30% turning out to be having advanced fibrosis. I think these figures are very, very alarming. So having said that, I think it's not only the cirrhosis and the the fibrosis. I think the HCC figures were also quoted by Kaushal. Again, to give you a snapshot, this is again a recent data of 850 patients with HCC from our center. And this is what we have seen, that over the years from 2010 to 16, the figures of NASH as a cause of HCC has actually gone up. And this is in line with, with the global studies which were shown by, Kaushal. So now coming to the, the management of a patient like this who's coming to you with, incidental detection of fatty liver disease or incidental detection of serous transaminases. So this is a typical, kind of a patient which would come to a physician or maybe to a hepatologist in liver clinic, somebody who's diabetic, who's hypertensive, is, kind of obese and has a weight of, say, maybe around 90 to 95 kgs, and then comes to you with incidental detection of transaminases. So what you do is, first thing you do is look at the anthropometry. So BMI, as per the Indian standards, turns out to be what we call class 2 obesity with BMI more than 30. Waist circumference for adults and males is taken as 90 centimeters, so centrally obese, 110 centimeter, and hepatomegaly on examination. You do the workup, look at the, liver enzymes first. So the AST more than ALT here, triglycerides elevated, HDL low. So this is a full house kind of, metabolic syndrome. Diabetic, hypertensive, obese, triglycerides cutoff, we take it as 150. HDL cutoff for males is less than 40. So I think all 5 components of metabolic syndrome. So this is a typical patient who's coming to you with raised transaminases. So what you do, you exclude all other causes of, hepatic steatosis and other causes of rise in transaminases, because as said by Akash, I think you can have hepatitis B and still can have fatty liver disease. So you need to exclude causes like, for example, Hep C is very, very notorious in causing hepatic steatosis. So all the, viral markers, autoimmune markers, I think you tend to do that. Then you look at the ultrasound, look at the severity of hepatic steatosis. So the first question, which was very well answered by Akash, is don't call these patients at NASH. Even if they have elevated ALT, this is not NASH. What we need to call them is try to look at what he told you, is look at the non-invasive assessment, look at their APRI score, look at their FIB-4 score, do a fibroscan if it is available. If not, maybe APRI and FIB-4 is good enough. We also calculate these days another score called FAST score. And based on this, you can call it as NAFLD with raised ALT with significant or advanced fibrosis. This is the kind of terminology I think we should be using, because NASH, again, the message is a histological diagnosis. You can predict NASH, you can predict inflammation, you can predict fibrosis, but to look at or comment about the ballooning or lobular inflammation probably would not be possible non-invasively, which is the hallmark or the histological hallmark for the diagnosis of NASH. Now coming to how do you treat these patients? I think we know this fatty liver disease is a lifestyle disease. It's considered as a hepatic component of metabolic syndrome. So you need to look at all these metabolic risk factors and focus on that. So irrespective whether the patient has overweight or obesity, physical activity or exercise makes, the major treatment, modality for these patients. Control of body weight. with, lifestyle interventions, control of diabetes, hypertension, dyslipidemia. I think there's no denying the fact that you need to control all these metabolic risk factors. In our patient, diabetes, hypertension, dyslipidemia, everything, needs to be controlled. I'll come down to the drugs later, but let's first focus on the lifestyle interventions. So as I said, you need to control all these metabolic risk factors. But then I think it may not be really possible for me to, give you all the details, what drugs to be used for control of hypertension, diabetes, and we do not use, the weight loss drugs in these patients. But I'll be focusing predominantly on the lifestyle interventions to reduce body weight in those who are overweight and obese. And, as I said, this is the major risk factor in them. Even if you are a normal weight, and the terminology called lean NAFLD, which is, which keeps revolving, especially in Indian subcontinent, where you have normal BMI, but still you have fatty liver disease. Many of these patients are so-called centrally obese, but we still call them as lean NAFLD, which constitute around 10 to 15% of patients in our clinical practice. For them also, I think the treatment modality, if you have to give them the lifestyle interventions, it has to be physical activity. There are so many other lifestyle interventions which are coming up beyond diet and exercise. Again, the time would not permit me to talk about coffee, the circadian rhythm, the jet lag, and the alcohol usage and all that. So I'll be focusing, as I said, mainly on the lifestyle interventions in, causing weight reduction. But before that, as I said, the metabolic risk factors, again, to give you a snapshot of our own data of around 4,000 patients, how common are these metabolic risk factors? At least one metabolic risk factor is seen in 93% of patients, almost everybody, and the most common is the central obesity, which is seen in around 83%. So I think we need to take care of, obesity or central obesity. And as I said, combined overweight and obesity would be seen in around 89%. So only 10-11% of our patients are so-called lean. So other than that, I think the weight reduction, whether they are overweight or obese, I think is the key lifestyle intervention for them. So now coming to how do you ask them to reduce body weight, and how do you, what kind of exercise, what kind of diet, and how much weight reduction. So these are, I've just summarized some of the, guidelines from the European and for the American Association, and even the Indian National Association of Study of Liver guidelines are under publication, where we are saying that depending upon the severity of liver disease, if it is just fat in the liver, maybe 3 to 5% body weight reduction is good enough. But if you're looking at reduction in inflammation, maybe 5 to 7% weight reduction is good enough. But if you're looking for reduction in fibrosis, then maybe 7 to 10% of your baseline body weight reduction is very, very important. Now, how do you do that? It has to be with combination of your dietary restriction and physical activity. So what kind of physical activity? Important ones are the aerobic exercises, which are in the form of, brisk walking, running, jogging, swimming, cycling, all these kinds. But those who cannot do the aerobic exercises, even resistance exercises, like that bands and the dumbbells, all these can also be used. And there is good data to suggest that both these kinds of exercises are good enough in controlling the hepatic steatosis. So as I said, in addition to, so how frequent, what should be the frequency of this exercise? Ideally every day, if not every day, maybe 5 days a week, and maybe 45 minutes a day, or 30 minutes to 45 minutes of every day. I think this is the kind of frequency which you need to do, and which should increase your heart rate, and you should be able to reach maybe around 70% of your maximal heart rate. I think that is the kind of, aerobic exercise you're looking for. As far as the calorie reduction is concerned, I think you need to reduce your calories maybe by 30%. Or if you need to tell somebody, maybe reduce the calories by 500 to 1,000 kilocalories. In simple language, I think if somebody is taking, say, chapatis, say 3 chapatis a day, I think you can just tell them to reduce it by, to come to, say, 2 chapatis a day, which is 30% reduction. So both carbs and the fats have to be reduced. It's not only, normally the focus is only on reduction on fat. It's not the case here. Both, it's the calorie reduction. Both carbs and fats have to be reduced, 30% reduction, cut down on the sugars, cut down on the sweetened beverages, cut down on the trans fat, fried food, processed food, sweetened beverages. I think that is what we need to tell our patients in general or in simple language, and cut down on the calories. So again, there's a lot of data. I can't tell you, go into the details about various studies which have shown about the lifestyle interventions improving the liver histology. But one study which, gave us the way forward was this French study, Swedish study, which was, in around 290 patients, 261 of them had paired biopsies. This is from Villar Gomez group. And what they showed was that with this, if you are able to achieve a weight reduction, there could be a resolution of NASH in around 25%, a reduction in NAFLD activity score in around 50%, and even regression in fibrosis in 20%. But the problem is that when you give them the target, the 5% weight reduction in this study was seen only in 30%, which means only 30% people could achieve 5% weight reduction. And when they looked at the figures at how many could achieve 10% weight reduction, it was only 10%. So which means that it's a little difficult to achieve the target weight reduction with lifestyle interventions. And in general, also people would prefer, pills and surgery rather than, doing the lifestyle interventions. And, as I said, some people may not be really be able to exercise because of their, osteoarthritis or other bony issues or cardiac issues. So for them, I think the anaerobic exercises, which I said, need to be done. But then we need to take the help of, various drugs to reduce their inflammation and, fibrosis. So before I go into the drugs, I think two emerging modalities, again, not recommended, which have shown some promise are the bariatric modalities, both bariatric surgery and the endoscopic and the bariatric metabolic therapy. Maybe we can have some discussion on this. But in the absence of randomized clinical trials and the morbidity which is associated with these procedures, still they are not recommended as first-line treatment for weight reduction in patients with fatty liver disease. Now, coming to the drugs which are recommended by most of the societies, including our Inazil. So 3 drugs, one is the pioglitazone, second is vitamin E, and third is saroglitazar. Now, where to get these drugs? I think Akash again showed you the algorithm which we are using now in the Inazil guidelines, which are under publication. So I think no doubt you do at the primary level, maybe APRI and maybe the FIF4, but say in a secondary level like ours, we just look at the, LSM or the, the liver stiffness measurement on FibroScan. And if the value is suggestive of significant fibrosis with a value of 8.2 kilopascals or more, and if they are not cirrhotics, I think we take a decision of giving them pharmacotherapy in addition to lifestyle interventions, even without liver biopsy. Most of the guidelines would say that you need to do a liver biopsy before you put them on pharmacotherapy. So for the first time, I think Inazil has come out with these guidelines where we are suggesting the use of NASH-specific pharmacotherapy even without liver biopsy. Now, how to choose among these 3 drugs, vitamin E, pioglitazone, and saroglitazar? Again, I think if you look at the data, I think the landmark study was the PEVENS trial, which showed us that both vitamin E and the pioglitazone are effective in improving the NAFLD activity score and in improving causing the resolution of NASH. But then they were not very good at improving the hepatic fibrosis. Thereafter, there have been many studies, and I've just put in one meta-analysis to show you that vitamin E is effective in improving not only hepatic steatosis, but also necroinflammation. Since the first studies were done in non-diabetic patients and in biopsy-proven NASH, I think vitamin E in most of the societies still would be recommended in non-diabetic patient and in biopsy-proven NASH. But on glitazone, especially, pioglitazone, we do have a lot of data now, even in diabetic patients. And the recommendations are that this drug can be used both in diabetic and in non-diabetic. And it's shown the improvement of, again, hepatic steatosis and inflammation. Now, coming to the drug, which is available only in India and approved only in India by DCGI, rather, this is the only drug which has a regulatory approval from, say, a regulatory authority like DCGI in India. So this drug, saroglitazar, is a dual PPAR alpha and a gamma agonist. We do have other dual, for example, PPAR alpha agonists, if you look at the prototype, are the fibrates. Clofibrate is the prototype, but again has not shown to be very effective. The prototype for PPAR gamma is the pioglitazone, which I just said, but now people are looking at the dual, PPAR alpha, gamma, alpha, beta, and I think saroglitazar is the alpha gamma. And again, I think I can't show you the large real life experience, for this drug was first approved for diabetic dyslipidemia in India. And during that time, they showed, they rather observed the reduction in serum ALT levels in these patients. And that's how it being started using in patients with NAFLD. There are two studies. One is the Evidences 4, which is a phase 2 study done in US, 4 arms, compared with placebo, and they showed that it not only improves, ALT level, but also hepatic steatosis based on MRPDFF, insulin resistance, and dyslipidemia in patients with NAFLD. In India, we had done this multi-center study of around 102 patients, those who were biopsy-proven patients with a NAFLD activity score of 4 and more, and they were randomized into saroglitazar of 4 mg versus placebo in 2:1 ratio. And what we found was that the reduction in NAFLD activity score was more than double in the saroglitazar group, 23% versus 52%. And based on these two studies and a lot of large, the real life experience, DCGI last year had approved this drug, for the usage in patients with NAFLD with F1 to F3 fibrosis without cirrhosis. So there are some issues with the standard therapy. I think I'll not go into the details. That's why people are working on a lot of, other future drugs. Again, the time will not permit me to get into all the details. For the sake of name, at least there are few drugs which have failed in phase 2, but the 4 drugs which are, are in phase 3 and look promising. One is the Resmetirom, which is a thyroid hormone receptor beta agonist. Semaglutide is a GLP-1 agonist. Ramchol is an SCD1 inhibitor. And we do have the interim analysis of a drug called obeticholic acid, which is a farnesoid X receptor agonist, and people are also working at the combination. So this is the study which was published with so-called the interim analysis of the REGENERATE trial, and which showed that the per protocol and the ITT analysis, the obeticholic acid was superior to placebo in improving the fibrosis. The problem with obeticholic acid are the side effects, the pruritus and the dyslipidemia, still not approved by FDA for usage. So ladies and gentlemen, let me summarize what I said in the last few minutes is when you look at the treatment of patients with fatty liver disease, NAFLD, look at and stratify these patients. All patients with fatty liver disease are not same. 18 years old boy with fatty liver is entirely different from a 60 years old postmenopausal lady who may have advanced fibrosis or even cirrhosis if you do the non-invasive assessment or a fibroscan in them. So then lifestyle interventions have to be recommended in all patients with fatty liver disease, whether they are lean, overweight, obese, and the control of metabolic risk factors cannot be overemphasized. Control of diabetes, good control of hypertension, dyslipidemia has to be done. In addition to lifestyle interventions, you can use the drugs where you think that your patient has significant fibrosis based on non-invasive assessment, maybe APRI, FIB4, LSM, whatever modality you have, and take a decision about treating them and adding pharmacotherapy, either saroglitazar or vitamin E, which is our larger experience, or pioglitazone. And maybe we can have discussion on this, how to choose between these, 3 drugs. There are a lot of people working on various drugs. The 4 important phase 3 drugs, which I said is Resmetirom, Ramchol, semaglutide, and obeticholic acid. And people are also looking at various combinations, but we still need more data on this. So let me thank you all again for your patient hearing. I'll be happy to take any questions. Thank you very much.
Thank you, Ajay, for overview of present status of management. I'm sure that the future is exciting, but we'll have to wait for the future. In the meantime, I'm happy to let you know that Dr. Sanku Rao has joined us. Dr. Sanku Rao is a gastroenterologist practicing at Oklahoma, USA. And he has been the former president of both American Association of Physicians of Indian Origin, API, as well as Global Association of Physicians of Indian Origin. Before I open for the question and answer, a couple of comments from Dr. Rao, please.
Oh, first of all, I'm sorry. I was given the time, 10:30 Central Time. So I had like 6 procedures I had to do and join. So my apologies for the timing was, they probably thought Eastern Time when I told them I'm on Central Time. So extremely sorry for that. Looks like you're doing a great job on this. So fatty liver is one of those things that I tell you, I think 25%, as the speakers must have already said, overall across the board. And it is a significant morbidity that can happen. And people are now realizing all those risk factors, change of their, I would say, their metabolic status, their lifestyle changes, which is the forefront of the treatment, in addition to vitamin E and some of the newer drugs. So I will let the session go on. I'll because you did the whole thing. I wanted to continue. I'll be just on the sidelines. Thank you.
No, Dr. Rao, we will not let you be on the sidelines. Where we would involve you at this step. So I think we have overshooted our time. But looking at the interest and the number of questions which are there on the chat box, I would extend the session for 10 more minutes from now. And I have picked up some of the questions from the chat box, as well as some of the things which were going through my mind. And I can take an order that we start with Kaushal Madan. So Kaushal, there is a question as to what should be the best way of community screening. We talked about rural India 2010 study by Das saying that it's 8%. And then you talk of more recent study where the rural and urban, there's hardly any difference. So what's the best screening method for community? And the second question, which has been put on the chat box, is nobody talked about smoking. Is smoking anything to do with the NAFLD? And Ajay did mention about lean NASH. This is a term which is controversial, I know, but has been overused, I would say. So what's the proportion of NASH which are actually lean NASH in India? So can you tell us about these 2 or 3 comments before we pass on to the next speaker?
Right. So I think if I were to plan prevalence study within the community, I think all the high-end procedures like ultrasound or fibroscan would not be cost-effective. And the most cost-effective strategies would be to find out high-risk individuals within the community and start screening them The first thing is to take history and find out the high-risk individuals. Second is to take a blood sample and just do an ALT. All these patients will then go on to the next stage of doing an ultrasound and doing a non-invasive assessment of whether they have advanced liver disease or not by a FIB-4 or an APRI. And finally, those who are found to have a high risk value in these tests would then be referred to a hepatologist or a center where a fibroscan should be done. So just at the base, at the periphery, you first have to start with finding patients who are at high risk of having NAFLD.
So what about smoking? Has smoking to do anything to do with NAFLD?
So smoking is not a risk factor for NAFLD per se, but there is some data to suggest that it may be associated with fibrosis or liver cancer, but not with NAFLD per se.
So Kaushal, you did talk about risk factors, and we heard about diabetes, 60%, hypertension, dyslipidemia. Is there a combination where the risk will be almost 100%? So do you think a combination of diabetes with dyslipidemia, with hypertension, with obesity will make somebody a perfect candidate, and you expect that 100% of them would have NAFLD?
So I think the worst combination is to have an obese diabetic. So obese diabetic would be the patients who would have the maximum risk of having non-alcoholic fatty liver disease, and this risk would increase with the duration of diabetes or having overweight. But I wouldn't say any combination which would reach 100%. But
so what about lean NASH? What percentage of NASH in India are lean NASH?
So I think if we go by the largest real life data, that is the ICON-D study, Dr. Dusija did mention about 10 to 12% patients will have lean NAFLD. And this is similar to all other previous smaller studies which have been done earlier from our country. So about, if you want to have a ballpark figure, then I think 10% would be worth remembering.
I'll move on to Akash. Akash, a couple of questions to you that we talked about MRI-PDFF. We also know that as the disease advances, even in the setting of fatty liver disease, the fat may not be discernible. So as the fibrosis develops, the figures of detecting fat by MRI-PDFF or by CAP scoring may be fallaciously low. So what's the solution? How do you know that etiology is NASH rather than you call it idiopathic or cryptogenic, because the fat may not be picked up by the non-invasive test? And you told us about the limitation of NASH being diagnosed NFLD, I mean, the fatty liver can be diagnosed, fibrosis can be diagnosed, but steatohepatitis continues to be a big problem. The final question to you is about artificial intelligence. I know that there is a lot of work which is going on in this country as well as outside, including Apollo Group of Hospitals. We have done some work on artificial intelligence, and I saw Dr. Nupun Verma in the audience. So he has also, I understand, a lot of interest in artificial intelligence. So can you tell us about the status of artificial intelligence in assessment of NFLD?
So I'll take up one by one. So firstly, about the fact. So it's a proven fact. We know these from the biopsy studies also. So as the disease progresses towards cirrhosis, you will be having more and more reduction of the fat to a point that in advanced cirrhosis, even compensated cirrhosis, there may not be any fat. So in such cases, which we label as cryptogenic cirrhosis and all, what becomes important is to look for history of metabolic risk factors like pre-morbid body weight, because once cirrhosis sets in, your body weight might not be there. So pre-morbid body weight, long-standing history of diabetes, other risk factors, so that would be there. So specifically in trial settings, MR-PDFF fat quantification in somebody who has got advanced fibrosis will not be a criteria because we are not expecting that amount of fat to be there. Coming to the question on artificial intelligence, there's been, I think, an uproar of data that's come out and it is coming up. So the issue with artificial intelligence, where it would be more and more applicable, are possibly two. One, identify people with significant fibrosis or activity, which is a problem that we are facing as we are discussing. Like we don't identify those patients with inflammation. We might identify fibrosis, we might identify fat, but identifying those patients with inflammation, with a large cohort of patients where artificial intelligence sets in, would be a way to look forward to. But the second most important thing is, I think, where we have biopsy data that's all there, is the use of AI in ensuring uniformity of biopsy reporting in trials. So that was the inter-observer variations that are there in biopsy reporting is something AI might be helpful. But as we know, the problem with AI is the data. Your intelligence is as good as your data is. So unless we give that good amount of data, we're not expecting. And the last part was about the inflammation. Inflammation remains the gray zone. That FAST score we talked about, there's another score called the MeFib4 score, which combines MRE with FIB4 and CK18, which have been used, but we need further validations of all those parameters. So that still remains a gray zone for us.
So Ajay, I think if I can ask you all the questions which are there in the chat box in my mind, we can be sitting for another 1 hour. But I think we'll just utilize 3 or 4 minutes which we have left behind. And a couple of questions which I picked up from the chat box and my own questions is intermittent fasting. There's a question about green tea. There's a question about what should be the lifestyle modification in patients with lean NASH. So let's start with these 2-3 questions, and then I have many more. So let's see how much can we cover.
Yeah, so before I go on to these questions, let me first add some of the thoughts on artificial intelligence. As you said, Dr. Nipun is there. So from our center, we actually collated data of, we have a consortium in Asia called GO-Asia, which is gut and obesity in Asia. So we presented this data in NASL, and we'll be presenting this data in next month in ASLD, where we have compared the utility of artificial intelligence in, looking at significant fibrosis in close to 1,650 liver biopsies done across 10 to 12 centers across Asia. And we have found them to be better than FIB4 and APRI. So just to cutting short, so there is a evolving role. So I think, as I said, this would be published. So there's a good role of AI which is coming up. Now, coming to the questions about one by one about the roles of various, modalities, say, for example, about the intermittent fasting. We just finished one study on intermittent fasting at the institute, and where we randomize people into a standard calorie reduction versus intermittent fasting, and we use the 16:8 intermittent fasting, regimen. There are various kinds of intermittent regimens. I think, again, the time will not permit me to get into the details, but the message is, yes, those patients, those who are not able to restrict their calories over 24 hours, you can make them intermittent fast, and intermittent fasting is very good in regulating your lipid and glucose metabolism and in causing calorie reduction and in improving your hepatic steatosis. The second question was about the tea and the coffee. Again, there's a lot of data, more with coffee, less with tea, and almost all of these have shown that these are very effective, or at least the population-based studies show that they are patients, those who are, say, coffee drinkers, say 3 to 4 cups of coffee a day, they have less of hepatic fibrosis within the patients with NAFLD. Less data with green tea, but then there's some data with green tea as well. What was the last question, sir?
So the question was about lean NASH. What should be the lifestyle model?
So the lean NASH, again, as I said, the crux or the pathogenesis, even in patients with lean NASH, majority of them, 60-70%, again, our own data and the rest of the data shows is nothing but the insulin resistance. They have what we call the visceral adiposity. They are centrally obese. We have even done the CT measurements of their visceral adipose tissue. It is equivalent to their obese counterparts. So the best medicine to improve insulin sensitivity in these patients is nothing but a good physical activity. So exercise is the most, and if they qualify for pharmacological treatment based on the degree of fibrosis, you can use the same drugs in addition to physical activity. The only thing is you may not like them to lose a lot of weight, but there's some data now which is coming in that even if they lose 3 to 5% of body weight within that lean normal body weight, the histology can further improve to, improvement in inflammation and fibrosis as well. So I think the approach largely even in lean patients is the same. It's only the degree of weight reduction which you can choose. Otherwise, physical activity and the usage of drugs remains the same.
Ajay, one question. You are in Chandigarh, and if you stop alcohol for all your non-alcoholic fatty liver disease, I think the economy of Chandigarh will be suffering. So what is your recommendation for alcohol intake in NAFLD patients?
To our surprise, I think, again, when we look at our patients, I think we have a cohort of, as I said, more than 6,000 patients now. See, there is we know that the alcohol intake in this part of the country, especially Punjab, Haryana, is much more than the rest of the parts. But then when we specifically look at cohort of our NAFLD patients, and we use this definition of less than 20 grams a day, to our surprise, most of our patients in NAFLD are actually teetotalers. This 20 gram also figure doesn't come in there. So they are actually teetotalers, not even a drop of alcohol in them. So we have two sets of patients, alcohol and the non. The problem in our setup is those who take alcohol in significant amount and have alcohol-associated liver disease, many of them actually have associated metabolic risk factors. Many of them are obese, diabetic, hypertensive, and we have published that increases the severity of their liver disease. So I think having a combination of alcohol and metabolic risk factors does increase the severity of liver disease. But as I said, most of our patients with NAFLD are teetotalers.
But what will you advise them if somebody from NAFLD asks you that?
Advice would be any liver disease, the advice is no alcohol, total abstinence whatsoever. But then again, there was some initial data which did say that the alcohol, especially some form of wine, could even be beneficial in improving the hepatic steatosis. I think that data has not been replicated. So if somebody asks you, I think the answer should be a big no. But yes, in moderation, somebody takes now and then a drink or two, I think that should be acceptable.
I think last 1 minute, Ajay, I would there's a question, and as I was also talking about is a national program. I think there's something which is called preparatory index, and it has been found that India is possibly very good so far as the preparatory index for NAFLD is concerned. Can you throw some light on that? And number two, I'm very excited
this is the data which was published, last year in Lancet Gastroenterology, Hepatology. We were part of this, the Delphi consensus which was done. And they were looking at the preparation of various countries in tackling this menace of fatty liver disease. So by that time in India, the program of NPCDCS, which is, the national program on control of diabetes, hypertension, and stroke and cancer, the NAFLD had been included in this program. So we gave them the feedback that yes, India is the country where NAFLD has now been included in one of its national programs of non-communicable diseases. So that actually gave us a lot of marks, and we scored 49 out of 100, and India was the highest scorer as far as the preparedness index was concerned. No country actually scored more than 50, and there were 30 countries who actually scored 0. So India is ahead. We are, better than others because we have it in the national program. But I think still we need to do a lot to implement this, at the community level or at the root level.
So I think with 35 to 40% prevalence of NFLD, hepatologists have a lot of work to do. But and I think that I should turn from a general gastroenterologist to a hepatologist for the rest of my life, so that there's a large volume of patients who will be continually coming to me. But I have Akash to take care of all these patients. And I think we'll have to wind up, though there are lots of questions, as I said. Dr. Sushil Jain, who is the advisor to the GAPIO, would give a concluding remarks.
Thank you, sir. And really scintillating talks from all the speakers. And thank you to all the speakers, as well as Dr. Govind, Dr. Mahesh, and Dr. Sankura. My apologies for that goof up in the timing. That's from my side, and my sincere apologies for that. I also would like to thank Dr. Sibal for joining in and opening the session for this topic. And thanks for the audience who has joined and made this successful. Also, thanks to my GAPIO team, including Dr. Alok and Jiten, and the IT team for making this a successful session. Thank you, everyone, and look forward to join you all for a better session, more sessions like this. Thank you.
Sure. I think it's a good cooperation between the two important societies, and we'll have more and more common interest sessions subsequently. Thank you once again. Thank you for the speakers and all the leaders who were there. Bye-bye.
Bye-bye.
Thanks for sharing that on my behalf. Thank you.
You're Dr. Rao.
Thank you.
Thank you.
Thank you, sir.